Hello. 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 Good afternoon. Good evening. Sorry. Good evening, everybody. As usual, we start with thanks to the Dean of Lokmanya Tilak Medical College, the head of the Department of Pediatrics, Sion Hospital, Lokmanya Tilak Medical College, and Aristo, the sponsors whose academic grant is helping us to conduct this clinic. Let's begin today. Today we have one case or two cases? Two cases. So the first case is by Dr. Manas from Hinduja Hospital. Is it Manas or Manasi? Manas.
Hello. This is a case of a 6-year-old male. This is a case of a 6-year-old male child, first by birth order, born of non-consanguineous marriage, informant being mother, and Muslim by religion, resident of Dharavi. They came with chief complaints of rashes on both legs 1 month ago, swelling and pain of bilateral legs 3 weeks ago, red color urine 3 weeks ago, and right-sided weakness and a paroxysmal event 2 days ago. Child was absolutely alright till 1 month ago, after which on 9th of October, child complained of sore and itchy throat, for which child was made to do warm water gargles. 3 to 4 days later, on 12th of October, after coming back from school, parents noticed red color rashes on both the legs. It was sudden in onset, present up to the knees, dark red in color and non-itchy and painless. Also, child complained of pain in bilateral ankles and knees and was unable to stand and walk due to the pain, for he which was uh, for which he was admitted elsewhere and received some medications. Rashes and pain reduced gradually over a week, and he was discharged. Child was also able to stand and walk. Next day after discharge, that is on the 20th of October, child developed swelling starting from bilateral legs, acute in onset, and gradually progressing over a week to involve both the hands and then the face and abdomen. Parents also noticed that child was passing red color urine at the same time, which was painless. Child also had fever for 2 to 3 days, high grade with chills, touching 101 to 102 degrees, requiring 6-hourly antipyretic but was active in interfebrile periods, for which he was shown to a local doctor who prescribed medications to decrease the swelling. Fever subsided, but urinary symptoms persisted and swelling also progressed. Child was referred to a kidney specialist who advised to undergo a kidney biopsy. Child was again admitted in the same outside hospital, underwent biopsy, and then was started on IV followed by oral medications. 3 days ago, while in hospital, mother noticed that child was not able to lift his right arm, and later on the same day was not able to lift the leg above bed, could only slide his hands and legs sideways. Also, child was unable to speak clear words and noticed to have deviation of mouth to the right side. It was sudden in onset, gradually progressive to the point that now there is no movement of right hand and legs, after which child was shifted to PICU and a scan was done. In PICU, child also had a paroxysmal event in the form of jerking of all the 4 limbs. The exact duration not known, but parents were told that it was subsided after giving some IV medications, after which child was transferred to our hospital for further management. There was no history of fever associated with rashes, no history of dyspnea on exertion, no history of generalized fatigue or paleness, no history of bleeding from any other sites, no history of abdominal or loin pain, no history of decreased urine output or pain during micturition, no history of other cranial nerve involvements, no significant past history. ANC history registered pregnancy, the ANC scans were normal, iron and calcium supplements were taken, no maternal illness during pregnancy. Birth history, he was born full term LSCS in view of meconium stained liquor. Baby cried immediately after birth with a birth weight of 2.5 kgs. No history of NICU stay and started on breastfeeds. Immunized according to national immunization schedule and optional vaccines not taken. Developmental milestones achieved as per age. Pre-illness diet history. Child is taking mixed diet by 24-hour recall method. Child has a deficit of 600 kilocalories and protein deficit of 2 grams. Socioeconomic. Family lives in a 10 by 10 feet house in a flat with 4 members in the family. Head of family is father who sells clothes on streets and mother is housewife. Father studies till 6th standard, monthly income of 10,000 and belongs to upper lower class according to modified Kuppuswamy socio-economic scale.
This child was absolutely alright 1 month ago, and on 9th of October, he was brought for sore throat and itchiness. He was brought for sore throat and itchiness, for which he was made to make warm water gargles, so that is okay. Then we come the next, after he came back from the school, parents noticed red color rashes on both the legs. It was sudden in onset, complained of pain in both left ankle, both the ankles, knees, and was unable to stand and walk, or for which he received some medication. So he came to you with rashes and pain on the 12th of October. He just complained that there was some sore throat, mild sore throat. There wasn't much fever, and with warm water gargles,
What is the age of
he
the child?
settled down. 6 years.
6 years.
So what would you do on that day when you saw the rashes? Sir, they non-Hinduja? Anybody from non-Hinduja? You will be given first preference because they probably know the case. So they will be biased in their discussion, but we'll have to analyze. Okay.
It can be a streptococcal infection, so we can start an antibiotic.
Okay. Why
Sore
do you
throat.
say it is a staphylococcal infection, number one? And where is the infection?
Because it's in the pharyngeal, so throat and
Yeah,
itchiness
so
along
that
with rash.
sore throat according to was staphylococcus, pharyngitis is streptococcal. Streptococcal pharyngitis with sore throat without
See,
fever.
To begin with, that sore throat had no fever. What kind of infection are you thinking? There is just sore throat. If I complain that I have a little sore throat, you will call me streptococcal infection and start an antibiotic? So what is that sore throat means to you? You get the point? Think properly of every small little thing. It could be still, yes. It could be any irritation. Okay. So we can't make much out of it. So leave it aside for a while. It may be mild infection. It may be any irritation, yes. But that is not important. You could have asked what irritation. For example, was there any running nose or postnasal discharge which was irritating? We haven't asked that. How do we know what that sore throat was? So let's not discuss that it's an infection and take the whole thing as a complication of infection. But talk about the rash now.
Now analyze the rash, please.
Also, any unusual new item they've consumed can also give rise to itchy throat, and that could be interpreted as sore throat. Now, a 6-year-old could have had something to some toffee or some colored food, or a new food item itself, and they could be allergic to it, and it is possible. Especially when there is no fever, one needs to take infection a bit more carefully.
I would ask the parents, sore throat means what? दुखता है क्या खुजली है? Okay, the child will say either खुजली है, that means it's not an infection at all. दुखता है, okay. So sore throat is a common word which is mistaken by different people.
Talk about the rash.
Analyze the rash, please.
You ask some more questions.
Yeah, exactly. You can.
Unless you ask some more questions, you won't know what rash that is. Okay. Ask some more questions to tell me what is most likely the cause of that rash.
You get more information about rash on history than on examination, many times.
Sudden onset rash, it could be allergic like urticaria or contact dermatitis.
Now, note the color which they have mentioned, okay? Dark red color, right? So,
Onset-
urticaria usually is not dark red color.
Was the onset very acute? Okay, was met warm girl after coming
Yeah,
out?
more or less on the same day, sudden onset.
It was sudden in
Painless.
onset.
Will you ask some more questions which are non-itchy, painless, sudden onset, multiple areas?
What happens suddenly is likely to be
If it is palpable, sir.
that we don't know, because we are analyzing the history.
Yeah, but it's okay. It would still be a differential. Go ahead. You are saying something. If they were palpable,
So the size, if they were palpable, as in if it could indicate purpura.
okay.
So sudden onset rash, bilaterally symmetrical, almost reddish. What should be the site of pathology? Is it in the skin? Is it in the bone, muscle, subcutaneous tissue?
When you see the rash, first job is to see whether this is likely to be a very serious condition. This is not. What are the serious conditions that you have to diagnose within 24 hours? Only rash. If you miss, child may be dead in the next 12 hours.
Meningococcemia. Okay, good. Why is this not meningococcemia? Why is this not meningococcemia?
If it was meningococcemia, the child would have, the primary concern would not have been the rash, it would have been how sick the child is.
Meningococcemia, okay, can kill you in the next 24 hours. So how sick is the child? This is not sick. Forget about it. Next is it a potential sick? Not sick today, but likely to be in trouble. What kind of rashes are potentially sick? Kawasaki? Okay. It will develop something. Maybe infection and complications, skin scalded syndromes, streptococcal, staphylococcal, but they all will have come with fever. So this is not serious rash. That much you know. Then what are the other rash? Exanthematous rash, mostly with fever, allergic rash, or a purpuric ecchymotic rash.
So
Straight away.
in allergic rash, you are talking about urticarial rash, or what are the other rashes that you think as allergic rash? And as sir said, potentially serious. SJS, right? SJS or toxic epidermal necrosis. And why do you think it is not the case? What is the hallmark of SJS? Mucosal involvement, right? Mucocutaneous involvement. So that's an important feature.
So this rash could be a bleeding rash. That much we know. Look at legs, joint pains. How do you connect bleeding rash with joint pains? Immunological. So we have got a story straight away that this is an acute immunological purpura with arthritis.
Where is the pathology? Vasculitis. When you say vasculitis, you must tell small vessel, medium size vessel, large vessel. Medium size, small vessel. So this particular child has sudden onset of rash suggesting allergic or immunological process, and the way it is described is likely to be almost like a hemorrhagic rash. So if you are there, then you would have seen whether the rash blanches on palpation, on pressure or no, for which remember that you have to have a glass slide, because you put a pressure and if it blanches under your thumb, you won't know that. So if it blanches, then it is rash. If it does not blanch, then it is purpura. So most probably purpura. Site of inflammation is small size blood vessel. Etiology likely to be immunological.
So pain is inflammation. So inflammatory, immune inflammatory, two organs involved, vascular and joint. You start getting almost a diagnosis. You don't know where it's going, but you start knowing what it is. So
And
what do you make out
You
so
know the
far?
distribution also, right? That it's, as of today at least, it is only on the legs.
Relatively symmetrical, restricted to lower limbs.
So
Now
what,
next.
what is the probable diagnosis at this stage? Vasculitis with joints.
Hinox-Schönlein purpura.
HS purpura. Okay. So next what happened? Also child complained of ankle, knees, he had difficulty in standing and walking. So it was painful. Why it must have been painful?
Because of the inflammation.
No, why was it painful? Because of examination.
Inflammation.
Inflammation, but every inflammation may not be painful. What part of the body was involved so that he was unable to stand? Can it be arthritis? So maybe because of inflammatory arthritis, he was not able to stand. So he had inflammatory arthritis associated with rash, most probably HS purpura. Then what happened? He was admitted.
Could it not be septic arthritis? Because he got sore throat, he has got fever, same infection could have given septic arthritis.
I mean, he's so bad that he can't even throw fever.
No, you're right. I'm just asking you what is the reason. Why would you not think of it as septic arthritis?
The joint pain, the distribution of joint pain is symmetrical, which is not
Correct.
so
Very
classical.
good. Also, the patient was able to walk even during the pain, so
And
that's
also
less likely.
multiple joints.
And now the fever is gone. So all the factors push you away.
So once you know it's a vasculitis, tell me now, small vessel, medium-sized vessel or large vessel? Small vessel. So now you know so much about it. Now you start looking multiple organs involved, so far two, small vessels. Okay. So we are already building up some story. But he gets better. Now what is that? Look
If
at
you
that.
were to see this child at that time, what examination would you have done of that child? He came to with rashes, pain, edema. What examination would you have that at that time? A, palpated the rash. For what? Palpebral purpura. Why palpebral purpura is different from thrombocytopenic purpura? Why is it palpable? Inflammation. There is inflammation, while in purpura there is no inflammation. So thrombocytopenic purpura is non-inflammatory because of thrombocyte decrease, and therefore it is not palpable. So I would have seen whether the rash was palpable or no. What else I would have done? In just 1 minute, I would have checked his blood pressure, because that's one thing that I would like to know, and other orders. Okay, so you saw him, maybe the blood pressure was normal, we don't know that. Next, what happened?
What would you anticipate? Suppose you were sending this patient home, right? They said the patient was discharged. So what would you tell the parents? What to look out for?
Hematuria.
Say in the mic so everybody can
Renal
hear.
complications can occur even after resolution of the symptoms, so we
Very good.
look out for hematuria.
Very good.
So involvement of kidney is most important. Any other organ? He complained of severe abdominal pain, unbearable. Pardon me? Vasculitis involving the intestinal. Okay, ischemia, bowel ischemia, another important thing. So we inquire for abdominal pain, we inquire for hematuria, check hypertension, and see the stability of the patient. Okay.
So
he
now
was
when he gets better, question is, was it a natural remission or a drug-induced remission? This cannot be natural remission as we anticipate. So it must have been a drug. At which time you could have asked, what kind of drugs were given? Okay. Must have given steroids maybe. But you should find that out. That would add on to say, yes, this was an immune suppression used by steroids, and then possibly he comes back again.
Next.
I've changed, sir. This is the next slide.
Okay.
And now passing red color urine. Okay. He gets back again, pain, etc. What is red color urine?
Now, how do you think about somebody complaining red
Hematuria
color
or hemoglobinuria or myoglobinuria?
or no blood in the
All are
urine and
red.
still red?
Or beetroot urea.
So the question is, if it was a hemoglobinuria, usually sick, myoglobinuria is very sick. If he was not very sick, must have been a hematuria. Moment is hematuria, is it kidney or is it the collecting system? How do you make out that on the history?
She said painless.
Okay, but is everything which is in a collecting system painless or painful? You are talking about only the calculus which can scan pace, but there may be
Or
painless
maybe
as well.
cystitis is
There
painful.
could be a
rather-
tumor in the
Yeah.
bladder, painless hematuria. So tell us the better difference between renal, glomerular and
Fragmented RBCs suggest glomerular causes.
so color of the, okay. So you could have said what color. That tells you whether it is really a glomerular, okay, or not. So there you get it.
You can do the 3-cup test also when whether the hematuria is more in the first part of the urine or in the terminal part of the urine. But that is more useful for bladder versus urethra, not so much of upper versus lower UTI. Okay.
But this could be a urinary infection as well. No? There is high fever with chills, 2-3 days. Why not a simple UTI only?
Swelling also.
I think swelling is also there, so I have to think of UTI. So sir is asking you, where is the anatomy of UTI? In the kidney?
Glomerulus or
What is it called? Infection of the kidney? Pyelonephritis, correct?
So could it be pyelonephritis?
The child is active in the interfebrile period, whereas in acute pyelonephritis, child would have been very sick.
he had high fever, interfebrile period, he was otherwise all right. So how do you analyze this? High fever for 2 to 3 days, interfebrile, child was all right. Though there was fever, was it a sick child? Probably not a very sick child, though the fever was high. So how will you analyze this fever? He settled down within 2 to 3 days with antipyretics. Fever subsided where urinary symptoms persisted and swelling progressed.
So the point is that if this is a UTI, hematuria is not a common presentation of acute UTI. Well, there could be microscopic, but not a macroscopic presentation of that. Sometimes a tuberculous disease might do that, but not acute onset. So this is related to the same immune system, and now we know that it's the skin vessels, it's a joint, and it's also the renal small vessels. You're getting a third organ involved. Okay, that's the thing.
Yes.
So then started on some oral medicine IV. So now tell us, we have mostly discussed these symptoms, right? There is no more symptoms. Is there any other thing on the next slide?
Then the child had some vascular. 3 days ago, while in the
Yeah.
hospital, mother noticed that child was unable to lift his right arm, and later on the same day he was not able to lift the leg above the bed, could only slide his hand and legs sidewards.
So
Also-
developed an acute vascular disorder, neurological. What does that mean now?
Once you have
Come on, what does it-
identified the pathology as vasculitis, so wherever the blood
CNS
vessels go,
vasculitis.
we can produce a problem.
Could
And the
it be
blood vessels go
thrombosis?
everywhere.
It could be a thrombosis also.
Then find out the cause for thrombosis. The commonest cause of such an accident, middle cerebral with hemiparesis, is the thrombosis. Do you think it must have been a thrombosis?
Could be a thrombosis.
What do you think? Could be?
Thrombosis secondary to some clotting disorder or bleeding disorder?
Secondary to his
See, acute vascular event could be thrombosis, embolism, hemorrhage, vasculitis, or a vasculospasm. Okay. Depending on how quickly, etc., fine. But here is the story of all immunological inflammation. No? Why deviate from that? You call it a vasculitis.
Same
If there was
vasculitis
nothing at
is-
all, you are thinking of thrombosis, you need to know whether there is a risk factor for thrombosis. If you thought embolism, risk factor for embolism. Hemorrhage is not only localized, okay, only to a small vessel. So that is out. Vasculospasm, some inborn error of metabolism come with paresis like that, melas, recurrent, all that is. But then the stories are different. So this is a vasculitic episode. So fourth organ involved, skin,
Also-
joint, kidney, and now this.
Also, please note the onset, slow onset. First the hand, then the leg. If it was hemorrhage, what would have happened? Acute onset, sudden onset. Child would have been rather sick. So often this is the onset of a thrombosis, not embolism. Embolism also may be more acute. So thrombosis, but here there is no thrombocytic disease, so vasculitis, lot of edema. So see what all vasculitis has done to this child. It has involved his kidney, it has involved his joints, it has involved skin, and now the blood vessels of the central nervous system. And where do you think the localization is? It was sudden in onset, gradually progressive to the point that there was no movement of the right hand and legs, after which the child was shifted. He was able to move along, but not above. What grade of power?
3.
Gravity eliminated can't do. Gravity eliminated can do against gravity. So, grade 2. Okay.
Sir, could this CNS event be a hypertensive complication due to renal involvement?
Possible. Because we have not had any idea so far about his.
The only thing against hypertensive is that there is no encephalopathy involved at the time of onset of the neurological deficit. And secondly, it has evolved over a period of time. Okay, over 24 hours. Hypertensive stroke would be immediate, a full and final kind of a thing. And otherwise, there has to be a raised ICT symptoms, and then you can say hypertensive stroke and worsening of the neurodeficit. So that is why hypertension leading to this unlikely, could be an associated feature likely.
Where is the localization? After which the child was shifted, there was a right-sided, and you said that angle of the mouth deviated to the right side. So right side deviation and right side hemiparesis.
It's a bit
When the
tricky
deviation was
because-
on the right side, where was the weakness?
Yeah, that's a bit of a tricky statement actually. Deviation to the right side means weakness of the left seventh now, typically.
So if left nerve and right side, so it is a crossed hemiplegia. That means the lesion is not at the higher level, but at the level of, it's like not the Weber syndrome, the other syndromes.
So basically,
Midbrain lesion.
ideally it would be a brainstem injury, but looking at the condition, it's most likely to be a middle cerebral artery, because that's the one which gets infarct or thrombosed most commonly, and parents may not have noticed or they may not have conveyed it correctly. I would examine this patient and make sure where is the seventh now before we jump there. Because typically vasculitis injuries, and why is this? Why am I saying this way? Why not brainstem? even that could give rise to a stroke. No? Why am I saying MCA? And to recheck myself.
Hemiparesis is diffuse, marked in the right side.
So there's speech also involved to some extent. That is one. Second, he had a seizure after that. That is another. But more importantly, all the vasculitis or thrombosis happened more likely in end arteries. So wherever there is an end artery, you are more worried about ischemia because there are no collateral supplies. So your MCA is technically it's an end artery, meaning there's not much of, at the top end you have collaterals, but basal ganglia and internal capsule, it's more like an end artery.
So can you summarize now what you have thought of?
Summary is most difficult.
Six-year-old male child with complaints of sore throat followed by red rashes on bilateral lower limbs within 2 days, followed by red to dark, it was not dark, red colored urine with anasarca, followed by sudden onset right-sided hemiplegia and deviation of mouth to the right side is a case of acute glomerulonephritis with nephrotic syndrome with stroke involving MCA territory, query thromboembolic, query vasculitic, DDs are HSP, IG vasculitis or HOS TTP or SLE.
Could now we discuss one of these pros and cons? All fit in. But let's discuss small differences.
Yeah. When all of them fit in, you need to say 1, 2, 3, 3, 2, 1, 2, 3, 1. That is where the debate is going to be. So who's voting in this order? What is your first preference? Most likely. HSP? Why? What is not fitting in HSP? See, whenever you make a diagnosis note, try to think what is most likely, then say points favoring, points not favoring, not fulfilling.
CNS involvement rules.
Very good. So CNS involvement is unusual in HSP. Can happen, unusual. Otherwise, things were fitting. Plus minus fever, rash, restricted to lower limbs, then arthralgia or arthritis, then renal involvement, and then some vasculitic event. So it could still be HSP, I agree, but that is something which is not fitting. Next is HUS TTP. What is fitting, what is not fitting?
Usually follows diarrhea or dysentery.
Okay. What is?
Features favoring are CNS involvement, fever with triad.
Sorry, say that again. I was trying to see the question.
Is joint involvement a manifestation of HUS? No.
Rashes? No. Rashes can be there, but only restricted to lower limbs, and symmetrical goes a bit against HUS TTP. Right?
So HUS less likely. One is, and what about SLE?
Age, male child, okay. Males
no
don't
other
get
manifestation.
Don't get SLE. Think we are so lucky? No. It's just that the distribution is less. I agree. And
First
even the
manifestation presenting like rash of this kind is also not common in SS. So this particular child probably had henoxon length purpura with PAS. If it was involving, we said that it is small arteries. So this has also to be small artery. Can small artery give rise to hemiplegia? As doctor said that it is middle cerebral artery. Is it a small artery or big artery? Middle cerebral artery can be a big artery, but the branches arising from that, which can result to neurological, is again a small arteries.
Dr. Mohite has asked a question, where is the lesion in CNS by history? But I believe we discussed that, and we'll wait for the examination to correlate the findings and then go ahead.
So I think largely I would have said that typical IgA, largely the purpura, severe abdominal pain and kidney. That's a classical one. Now there would be an overlap, yes. So possibly not the neurological episodes. When it comes to HUS and TTP, both look very similar, but TTP often with a neurological problem, HUS less likely with neurological problem. So again, in favor or against, one would favor then not HUS. Again, you will see evidence of hemolytic anemia on examination, which we have no clue so far. So that's where it is. And when it comes to SLE, again, a male child, not necessarily that. SLE can present with one of these symptoms for a while, but then some skin rash, typical butterfly rash, etc. Okay, arthritis is not so painful, acute, so possibly not an SLE. So I think we are open to all this. There is an overlap on this, but might be one over the other likely as a standard presentation. But we have seen the overlaps, so this is quite all right.
This CNS thrombosis goes in favor of SLE or against SLE?
Yeah.
We discussed against HSP in favor of HUS, but what about SLE, CNS?
SLE is a vasculitis.
Yeah.
TTP is thrombosis.
But HSP is one of the major cause of stroke in children. So neuro-SLE is a known entity and can cause it. As sir said, pathophysiology may be different. And just on the same note, HUS TTP previous, some people used to put it as same and extended spectrum. But now most people put them as a separate entity, though overlapping symptoms.
Let's see the examination.
Child was examined in supine position. Child was awake, conscious, but lethargic and not interested in surroundings. Pulse was 60 per minute, regular rhythm and good volume. Peripheral pulses well felt. Afebrile. BP of 120 to 80 mmHg, 95th to 99th centile, taken on right brachial artery in supine position. Respiratory rate 16 per minute. SpO2 98% on room air. Pallor was present. Edema present over bilateral legs up to the knees, more on right than left, and bilateral hands up to wrist, and periorbital and abdomen. No icterus, clubbing, cyanosis, lymphadenopathy. Rashes had disappeared at this point.
So at this point, whatever we have so far, can we now put one over the other of our probabilities that we talked about?
And also when we are at it, Dr. Bharti Khanna from Pune is asking, could this be a polyarteritis nodosa? Because we are debating whether this is a small vessel vasculitis, so why not look at least some medium vessel vasculitis also? Because we have rash, arthritis, hematuria and CNS.
So who can put one over the other of our initial 4 probabilities? What do you make out? What is striking at you on this slide in terms of physical findings?
Which organ?
Blood pressure, bradycardia.
So looks like a generalized edema. Okay, so let's call it a nephrotic syndrome. Now go back to your 4 first probabilities and tell us which one of this is likely to present as nephrotic syndrome.
So HSP mostly.
Yeah.
I honestly don't know the answer to this. So I would vote for saying that nephrotic syndrome, we normally say SLE with secondary nephrotic. But all of them primarily cause nephritis, the glomerular affection.
And so nephrotic syndrome is nephritis only.
Yeah, so it's a nephritic
so
onset
again, we
of
are
nephrotic
open
syndrome.
to all. Okay. Because nephritis and nephrotic syndrome are same. Only when there is a massive edema, we feel that it's not the endothelium but epithelium that is involved. But after all, they are all so close together microscopically that one gets over to the other, and it is best we call it nephritis, and all of them will cause nephritis. So this does not tell us anything beyond what we said, right?
Also, just as somebody else pointed out here, Dr. Mahesh is also pointing out, 60 per minute for a 7-year-old child is bradycardia, especially with hypertension. And also, if you see, even respiratory rate of 16 appears to be low. But since the child is otherwise alert, awake and fine, that should be okay. You have already written peripheral pulses well felt, but it's good idea, as Dr. Mahesh says, if you are dealing with a vasculitis or a collagen vascular condition, say all 4 peripheral pulses were checked and they were normal. Because if you're talking about polyarteritis nodosa or Raynaud syndrome or something like that, you may have one of the limbs showing less volume or no pulse on that.
Yes, for abdomen.
On inspection, abdomen is distended uniformly and flank fullness is present. Umbilicus in midline and slit-like. All quadrants of abdomen move equally with respiration. No visible pulsations or dilated veins. Skin over abdomen is stretched and shiny, but no striae. No hernial orifices.
So what do you conclude? What has happened?
So you have a nephrotic syndrome. That
There
is
is
nephritis.
ascites.
We said that.
There may be edema of the wall, abdominal wall also. Okay. Next.
On superficial palpation, skin is warm, abdomen is soft and non-tender. On deep palpation, liver and spleen was not palpable, kidney non-palatable. On percussion, fluid thrill was not present, but horseshoe-shaped dullness was elicited. Shifting dullness was present. On auscultation, bowel sounds were present.
It's okay, go ahead.
CNS, higher function, child is lethargic, GCS of E4, M5, verbal couldn't be assessed, and slurred speech was present. Second cranial nerve, pupillary reflexes were intact. Visual field by confrontation, child was not following eyes on the right side. 7th cranial nerve, a deviation of angle of mouth to the right side, no eyelid toss is seen. 9th and 10th cranial nerve, gag was present and uvula was in midline. For 12th cranial nerve, tongue was in midline. Other cranial nerves could not be tested. On motor examination, child was examined in supine position with right upper limb and lower limb was lying flat on one side and left upper limb and lower limb was semi-flexed. A hypertonia present in right upper and lower limbs. Power on right side was all 1/5 and on left side also 3/5 it was. Reflexes, right side biceps, triceps, knee, ankle was 3+ and ankle clunus was present. On left side, biceps and tricep were 2+, knee and ankle was 3+. Plantar's extensor in right lower limb and flexor in left lower limb. Sensory and cerebellar examination couldn't be tested. Other systems were normal.
So what has he got?
Somebody interpret the CNS findings. You can go back one slide. Yeah. Start quickly. We are to the second case also. It's not difficult, right? It's very nicely written, all the CNS findings, so you can interpret them.
So what are the positive findings? Weakness on the right side with hypertonia and breast reflexes. Also please note that the left side is also absolutely not normal because the power is grade 3 while it is grade 1 on the right side is grade 3. One would not expect affection of power except maybe in the early stages which is expected to recover. Then why not bilateral hemiplegia? Because the plantar is still flexor on the left side and its extensor on the right side.
Also
So
the reflexes on left side are 2+.
Yeah.
Ankle he has written 3+, that's fine. That ankle is always difficult to quantify. But knee is also only 2+, and plantars are flexors. So we may not pay that 3+ may still be the, I would even put it as could be normal also. You may not have a lesion for that.
Now comment on the cranial nerves. Where is the cranial nerve finding? Yeah, deviation of the angle of the mouth to right side. So which side is weak? I beg your pardon. Left side is weak. Where is the paresis? In the limbs, on the right side. In the face, on the left side. And what has happened to the eye movements? He is not able to move the eye on the right side. No, sorry. Not following the eye on the right side. So that is a little difficult to explain. That right side is not able to follow. So right ocular muscles or rectus is not working. On the left side, the left facial is not working. And the hemiparesis on the right side. Can you explain that? It's rather difficult to explain both the things.
So that's what Dr. Mohit is also asking. When you say not following eyes on the right side, do you mean one eye is not following on the right side? Then it could be the lateral. Suppose the right is not going to the right, then you're talking about a lateral nerve palsy. The sixth nerve palsy.
The eyes, they were not following like...
so it's like a gaze palsy you're saying?
No, it was like visual field is gone on the one side.
Okay, so he's talking about like a hemianopia.
Oh, you are talking about hemianopia. So when you shine but was there any difference in the pupillary reflex when you shine it from right side and take it to the left side? If there is hemianopia, and when you shine the light on one side, the right reflex is present. As you go on the other side, the light reflex may become...
He's saying you are not able to identify, I mean the visual field on the right side was not there, that's what you're saying? Yeah. Okay, fine. So how do you interpret that? Any large middle cerebral lobe, middle cerebral artery will give rise to hemianopia also because of affection of the optic radiation and optic tract. So only one part is affected, it can be quadrianopia. If more than one part, then hemianopia. I am open to correction on that.
And often it is not diagnosed because we don't see the visual fields very acutely.
In adults, they regularly check and it's diagnosable. If you read Harrison, you will clearly see pictures in stroke about hemianopias.
So one thing is definite, that he has a crossed hemiplegia or crossed hemiparesis. Hemiparesis on the right and lower cranial on the facial on the left side. So these are in the pons or little lower down. What else now? That doesn't help us much, whether it was same side or with the other side. But as you pointed out, it is just difficult to explain a seizure.
But sir, if it's a hemianopia, then it has to be up there. The only other way, if it's a gaze palsy, then you can still have a third nerve nuclear palsy, and that will have a gaze palsy, and then you have a brainstem injury, and you can explain those two. Still, you can't explain seizures.
We don't know whether the seizure started focally and it was generalized, because we may not have seen the onset of seizure. So we'll keep it at that. Okay. So what's the final diagnosis?
Dr. Narendra Rathi is saying looks like multifocal involvement of brain which occurs in vasculitis. We generally try to
restrict to one lesion.
Say if possible to explain on one, but if not, there are conditions where vasculitis will give rise to multifocal involvement. And tuberculosis is the classical example where you have various lesions. Similarly, you have ADEM, which is not a vasculitis, but you can have asymmetrical multifocal lesions. And in adults, even multiple sclerosis and ALS, where you get mixed signs.
I think we don't know clearly the third, fourth, sixth on this child. That is not mentioned. And therefore, question is it really multifocal or not? And we don't know about the joints. Apparently, joints are all right. So we are talking about joints, whether joints are still being seen as inflamed. Okay, is there a persistent arthritis, or there was only arthralgia? There was a swelling also.
I missed the joint examination.
No, but you can say it even if you're not.
Till the child came here, in one day the child worsened with
There's no pain when you examine the child.
Passive movement did not elicit any pain.
No, it's likely. After all, multiple areas involved. Not every time all areas will be present. This child has had some treatment, so one area is getting better. First time we saw that he got better for a while. So you may not have a joint there, but it means that there is no sequelae. Okay, why is no sequelae? There was an arthritis, swelling and pain, and multiple joint. Why do you think there is no sequelae? I have seen only rheumatic arthritis without sequelae. Rest all have some sequelae. Why is this child having no sequelae? Why does rheumatic arthritis have no sequelae? This must be one of that kind of arthritis. Okay. Why does rheumatic fever not leave any sequelae? Sequelae is only on the heart. And therefore, the reason is that an acute inflammatory response quickly reverts back, and there is no time to develop a permanent sequelae. But when it comes to the heart, we know that every rheumatic fever has a subclinical carditis, whether you know it or not. And that is likely to leave behind, not in all, but in some. In other words, this inflammation seems to be acute in onset, but also recovering fast. And that's why possibly the rash came, disappeared. Okay, joints, no joint at present. That is all that we know. So looks like an acute onset inflammatory condition which is responsible for your immunosuppression and not leaving behind any sequelae. Okay, that is all that we know. So we are not surprised that their joints are normal today, skin is normal, that's still likely. But here we are not sure about multiple areas of vasculitis in the brain, etc. or not. Okay, the commonest condition that one has seen multiple vessel involved is not vasculitis. Then what is it? We don't know the cause. Moya. Okay, typical multiple vasculitis, vascular lesions, right?
Or you have a condition like Sir said, Melas or other mitochondrial disorder, where it is recurrent and hence multiple. So one time one area gets thrombosed, and then by the time it's not recovered completely, something else gets involved. And then when you examine the patient, you will have multiple signs. But there will be a history of timeline which is different than this.
Tuberculous vasculitis is multifocal, as we know that. It's one of those things which is multifocal.
Has some investigation been done? Yeah.
So to summarize, 6-year-old male child history with complaints of sore throat followed by red rashes, hematuria, anasarca, then sudden onset right-sided hemiplegia, deviation of mouth to right side, one episode of GTCS, on examination hypertension, edema of extremities, orbit, on general examination ascites present with right-sided hemineglect, hypertonia of right side with loss of power and brisk reflexes on the right side, would be a case of acute glomerulonephritis with nephrotic syndrome with stroke involving MCA territory, query thromboembolic or query vasculitic, HSP-IG vasculitis.
Investigations.
This was the rash photo which was shown on mobile by the mother. Not very clear. These are all the outside investigations done in outside hospital. The hemoglobin was in falling trends, and so the platelet counts, and creatinine, which was in mostly in rising trends. The total proteins and albumin was low. The C3 ASO titers was normal. ANA showed speckled pattern 1:320, and DSDN and ANCA was negative. The urine routine report showed RBCs and occult blood and protein, and a UPCR ratio was on 31st it was 15.3. On peripheral smear, it was predominantly microcytic hyperchromic cells with schistocytes, occasional spherocytes. Retic count was normal, and also beta 2 microglobulin APLA was done, which was negative. The ANA was positive, suggestive of some overlap syndrome. Lupus anticoagulant was normal. This was the kidney biopsy report, which it revealed markedly enlarged viable glomeruli and ill-defined lobularity with proliferation of endothelial cells and mesangial cells and neutrophilic infiltration. Also, cellular crescent was seen. So, yes. This was the outside. This is the outside MRI, which was done when the child developed stroke. And the MR angiography.
Yeah.
Any point on MR angiography? The left kidney.
So now, non-hemorrhagic infarct involving left middle cerebral artery territory, involving left frontoparieto-temporal lobes and posterior insular cortex, and reduced caliber of M2 segment of left MC territory. Now currently here the child has developed left-sided hemiparesis also. The infarct has actually increased in size. There is total cutoff of the this left
Louder,
MC.
please.
Now there is total cutoff of the right MC artery. He has developed the hemiparesis. It has increased in size, and also creatinine is continuing in the rising trends. Maybe we would plan for dialysis also now for the child. And we had done a 2D echo also for a stroke workup, which showed 7 millimeter ASD also. Though on clinical examination couldn't find any significant murmur or anything.
Thank you very much. Who's presenting next? Dr. Pankaj?
Sir, I had just one thing to point. When we asked them, how will you discuss and summarize? All that they write is a summary. They just describe what we have done. They have just described that he presented with this and his signs were this. But they have not analyzed. What I mean is, when we ask you, how will you discuss, we don't expect you to say everything in the form of summary. That is just a mechanical thing, so to say. We have to make an effort as to analyze histologically, pathologically, etiologically. So it's not very easy, but may I attempt that this particular child basically presented with various manifestations of vasculitis, probably small vessel vasculitis, which initially showed a Hinox-Schönlein-like picture, the transient arthritis, which went on to develop kidneys and glomerulus. So far we are okay with involvement of small vessel vasculitis. Later on it got extended even to the vessels of the brain and the cerebral, and therefore the diagnosis of vasculitis is the primary diagnosis, which stays which involves multiple organs and therefore multiple types of presentations. The etiology of vasculitis we don't know, may not be inoxonal, maybe IG mediated. Therefore, this particular child had basically vasculitis, which has given rise to multiple organ involvement. Now he's on dialysis, even kidney is involved. The skin and joints have escaped. So now it's the kidney and the brain without any hypertension. So I thought I would analyze this like this.
I think possibly you asked possibly about the encephalopathy. So now retrospectively it looks like that this child has thrombosis and hemorrhage, the combination of the two. Now, if we had picked up encephalopathy, what he was asking for, okay, where apparently I had not thought of a clear evidence of an encephalopathy, but if it was an arterial stroke, then that kind of encephalopathy was unlikely, unless it was a venous stroke. And therefore that could have made us consider whether there was a hemorrhage also, and a thrombosis and hemorrhage put together puts one of those later ones and not the earlier IgA vasculitis, etc. So I think we learn out of this that to pick up some, you did ask for that, but we thought that there was no clear evidence of encephalopathy. He said some lethargy, and the GCS was reasonably okay, what he could test. But in retrospect, possibly the details of finding out encephalopathy would have made us say that, no, this is not only the vasculitic of a localized arterial stroke, but it is probably a hemorrhagic stroke. And that would have made us into an encephalopathy. So your question, I look retrospectively, was very valid.
You are from LTMG.
I'm presenting the short case.
No, in the mic, please.
4 months old male child, third by birth order, born out of non-consanguineous marriage, Ansari by community, Muslim by religion, resident of Govandi, brought by mother with complaints of increase in size of head since 4 days and irritability since 4 days. Patient was admitted 20 days back. Child has significant birth history, so I would like to start from antenatal history. Gravida 3, para 2, 1 alive 1 and live 1 and aborted 1. Registered pregnancy. 3 NC scans were done. Suggestion of short left-sided femur, tibia and fibula. IFA tablets were taken. Known case of DM on insulin. Intrauterine fetal death 10 years back. No history of smoking or alcohol intake or radiation exposure. No history of fever with rash or PIH or thyroid dysfunction. Birth is birth history, very preterm, 29 weeks, very low birth weight. Birth weight was 1.2 kgs, delivered by LSCS in view of bleeding placenta previa. Baby did not cry immediately after birth, required resuscitation for 30 seconds, then got intubated for respiratory distress. Postnatal history. Patient was admitted in NICU on ventilator. Surfactant was given, developed jaundice on day of life 5. Received phototherapy for 3 days and 3 PRC transfusions were given. Had convulsions on day of life 15 in the form of clonic jerky movements, started on anticonvulsants. Patient surgery was done on right side in view of increasing size of head on day of life 28. Some imaging was done before that, and baby was extubated on day of life 29. Required O2 therapy for 1 more month. Child was discharged after 2.5 months on full pits and on room air. Some eye test was done and parents were told that baby has bilateral mature retina. History of presenting illness. Patient was apparently alright 24 days back when mother noticed increase in size of head and irritability since 4 days. No history of sunsetting of eyes. no history of poor feeding, no history of vomiting, no history of fever, no other signs of cranial nerve deficits, no history of contact with TB, COX. Patient was admitted in pediatric surgery ward where he developed posturing and had one episode of convulsion in the form of tightening of all four limbs. Then left-sided VP shunt surgery was done. Child developed fever spikes on post-op day 3, which was high grade, continuous, subsiding with taking medication, active during interfebrile period, not associated with rigors, not associated with fever with rash, no history of vomiting, no history of repeat episode of convulsion, no history of decrease in appetite, no history of ear discharge, no history of cry during micturition, no history of cold or cough. Baby is immunized till 2.5 months. Developmentally, gross motor, there is a complete head lag, and fine motor, there is hand opening present, speech and language cooing is present, and social smile is present, and he recognizes mother. So there is gross development, there is a gross motor delay. Dietary history: child is on breastfeed and formula milk with improper dilution. Patient has one more sibling who is normal and is 8 years old. They belong to the upper lower class according to modified Kuppuswamy socioeconomic scale. On examination,
Don't show that. Go to the first slide.
Hello, no history is given. That you are the doctor, the child is put on the table in front of you. Doctor, dekho. What will you see?
I think don't take the whole story if that is told to us. Okay, just opine on this slide only.
And before taking history, just look at, so if you see a child with big head, in other words, I am asking you, if your child is a big head, how will you analyze?
Acute onset of increasing head size for 4 days. Okay? In a 4-month-old child, and irritability. What does that mean? Forget the previous story. Then the whole thing becomes easy to understand. What do you make out of this acute onset, large head?
So he's mostly developing some hydrocephalus.
Acute onset?
An obstructive type could.
It could be noticed since the last 4 days. I mean, it could be a slowly developing thing which was noticed in the last 4 days. Slowly developing hydrocephalus.
What does irritability mean? A common, usual hydrocephalus in small infant is not irritable. He has a large head, but no irritability. What does irritability mean? Raised ICT. So this child has got a raised ICT with a large skull. Large skull is obviously space occupation. The common space occupation is hydrocephalus. But it could be a large hematoma. But there is no story to account for large hematoma. So what I want to stress is, just this much is enough to say that this child must have had hydrocephalus even earlier. Then why did it acutely come up? So the shunt got blocked. So you almost derive that there has to be a hydrocephalus behind. There is no acute onset hydrocephalus. Okay. And there is no other story. So raised ICT with hydrocephalus, acute onset, must be a shunt blockage. Now, whatever the cause of hydrocephalus, that we don't know on this slide. It could be a congenital abnormality of the ventricular pathway, but we know that the complication has occurred possibly because of the block shunt.
Yeah, no history is available. I see a child with large head. I have no history. How will you analyze large head?
Check the parents' head size.
Pardon me?
Check the parents' head size.
Parents' head size. Okay, so see whether the head is really large or no. It is large, crossing all the percentiles. So what it could be large due to?
Next step in your thinking. First question is correct. Confirm
Large head, agreed.
next.
So large head will be large because of?
What is your algorithm further?
Bony abnormality or abnormalities intracranially. Intracranial abnormalities can be a result of increased amount of cerebrospinal fluid, or it could be as a result of increased cerebral matter. Bony abnormalities can be as a result of some disorder. We know you said that bones were smaller, like an achondroplasia where the head is apparently big. The intracranial pressure or increased amount of fluid can be either hydrocephalus, or please don't forget it could be subdural collection of fluid also. So large head is bone, intracranial. In the intracranial it's the fluid accumulation. The fluid accumulation is outside the ventricular system or in the ventricular system, or the ventricular system is normal and this child has megalencephaly, and then further analysis. Here, of course, the history said. So if you don't, and then if you palpate, of course, on examination, you will find that the sutures are open, etc. But just if you see it at large head, this was too obvious. But otherwise, these things should pass through your mind without jumping to the conclusion that every big head is a hydrocephalus.
Just be careful here. We have been told it's one-sided shortening of femur and tibia and fibula. Am I right? Correct? Okay.
Could it be any fastly developing malignant tumor which is obstructing the ventricular pathway and causing raised ICT and an hydrocephalus? Okay.
I'll translate, make it easier. Instead of tumor, space occupying lesion. That also you can mention. Anything other than tumors.
This is a very rapid progression for any space occupying lesion.
No, so asking what can cause rapidly growing hydrocephalus? Acquired cause.
Such a fastly developing tumor is not an issue. 4 days, how can it do that? But could a chronic subdural hematoma do that? A forceps delivery? Apparently all right. Hematoma goes on increasing, it's a subdural, it goes on, it's a venous bleed. So slowly increases, it's not an arterial bleed. So presents at 2, 3, 4 months with a large skull, and we call it a hydrocephalus. It may not be hydrocephalus, it's a space occupation. Could it be that?
Subdural hematoma is
Typical
asymmetric.
story, 2, 3 month old subdural hematoma. What is lacking for it to be called any such localizing mass, which is compressing on the ventricular surface? There would have been a focal signs, and such a patient comes with a focal seizure maybe.
And one of the common methods of presentation is large head, vomiting, and failure to thrive. That is how a subdural will present. Maybe in the early part of life, if you had done a commonly not done examination, which is transillumination, then you may have a clue to the diagnosis of subdural hematoma. And also they said that the type of hydrocephalus in subdural and in intracranial is different. In, I think, subdural, it is the posterior fontanellae which are more important, and in hydrocephalus is the anterior, the frontal lobe is more important, or the other way around. But clinically we can make that diagnosis. And of course the large sutures, etc.
Could it be late onset hemorrhagic disease? Vitamin K deficiency coming late onset intracranial. Hemorrhage, intraventricular hemorrhage, hydrocephalus. Just give a thought. We're just considering, certainly this is not, obviously, But these are all probabilities that you go through your mind.
Usually whatever bleeds inside later on will compress the brain first and give you signs, then expand the skull and give you a large head. So that's why we don't really think about HDN immediately causing a large head. Any hemorrhage can cause obstruction. So what I was asking you was if there is a pinealoma or anything like a third ventricular, the cyst, CSF cyst just below the third ventricle. These are the things which cause obstruction, and then that can give rise to only the lateral ventricular hydrocephalus. These are some of the acquired causes of hydrocephalus. And it's important to know because in these cases, just putting a shunt may not work because you have to have both sides or you have to do an EVD.
So just don't come to the conclusion that every large head is hydrocephalus. That's the message.
So Dr. Mohite has raised a point that late HDN is usually not intraventricular hemorrhage, and that's why does not cause hydrocephalus. So what we were saying is the same thing. If there is an obstruction due to a hemorrhage, that means intraventricular, then you can expect hydrocephalus, but compression from outside not causing hydrocephalus in large
Before
head.
we go for examination now, what must be the cause of hydrocephalus in this baby? Congenital? Or due to some disease?
How do you decide suspect congenital versus acquired? Congenital, perinatal and acquired.
In congenital hydrocephalus, the antenatal scans might be showing some abnormality.
Accepted. What else? Difficult labor. Very good. Okay. Then large head noticed at birth. That's the third thing. Perinatal cause? Sorry? IVH. Very good. And pyogenic meningitis. Right? So you will have history which is suggestive of either of the two. Then you will think about perinatal cause. And then acquired. Acquired again you should either have an insult or you should have a reason. Now the cause may be congenital, like aqueductal stenosis, but hydrocephalus may develop later on. So that also you may need to keep in mind that the size was becoming larger but not big enough for the parents to notice. And then you noticed it afterwards.
See, acquired perinatal cause would have been an infection.
Yeah. Pyogenic meningitis.
That's not there. Could it be a congenital toxoplasma? Small birth weight? Okay. Congenital infection. Toxoplasma present with hydrocephalus has a multiple system involvement. Okay. Could it be a toxoplasmosis? See, when you talk about hydrocephalus, you have intraventricular hemorrhage, you have a meningitis, or you have a meningitis like a toxoplasma. Give a thought, doesn't matter. Okay.
So there would have been IUGR. I think it was appropriate for gestational age.
Okay.
But at 29 weeks.
Anything else? Just think in your mind, how would you describe a baby with intrauterine infection?
That's
There
right.
would be a microcephaly.
Yeah, would be a microcephaly. So it's a ex vacuum dilatation because of the shrinkage or affection of the brain matter. There is a fluid collection and the ventricular size is bigger, but not the head size.
But typical toxoplasma will come with hydrocephalus. The point is they are not acutely sick at birth. Okay. They seem to develop all the sequelae as the time goes, but they are not acutely sick because the event has occurred much earlier in pregnancy. Okay. And if the event has occurred very early in pregnancy, in fact, there is a chance that it will be a severe problem thereafter. So you can imagine this is 5-6 months old intranatal, and therefore there is no acuity of presentation. Whereas this child is sick, is needing ventilation, etc. Any congenital infection will not be sick at birth, especially if it presents with all intracranial problem, because it is already a chronic infection and they are not acutely sick. This is just to get on what are the cause of hydrocephalus at that age, right?
And if you have to think of congenital, then it must fit in one of the three causes, like aqueductal stenosis or Bernaschiali form of pressure or Dandy Walker. And on your MRI, you will have the diagnosis of either of three. In the absence of that, is less likely to be a congenital malformation.
Now, such a small child, don't make a mention of active during interfebrile period, etc. I know that we have been talking about that kind of a thing, but not in a small infant.
So actually my question was going to be, do you think this is a viral disease because the child is active interfebrile? I take his history absolutely right. In this situation, would you consider that as a viral infection? 3 days of fever, child is interfebrile well, started with high fever. So is it a viral infection? Yes or no? Would you give antibiotics? Not give antibiotics. Say it.
So it's post-op CNS. So
Correct.
central
This is
fever.
post-op CNS. You have put in a foreign body. You have to think of it as a bacterial infection till proved otherwise. Correct? We are clear on that. But as Sir said, we don't talk about interfebrile well or not well in this child. And also when you say fever is continuous and then you say interfebrile well, that also sometimes causes a problem. So just be careful about what adjectives you use. So the patient is here.
Yeah, patient has.
You have a bed sheet here?
1 minute, sir, I'll sit down. Come on, 1 or 2 volunteers.
See, again, try to give your vitals correctly, okay? Small baby, 4-month-old, RR36. It's going to be unusual. Not saying impossible. Sick child, hydrocephalus, shunt, operated.
Do you want to put off the ventilator, the air conditioner? Or no need? I remember in MD exam, when I was an examiner somewhere, a newborn came and my co-examiner asked the candidate, is it all right if there is an AC? He said, if you like, that's fine, but you pass me, bus. I am okay with anything. Okay, he was giving him a clue. Is it okay with an AC? He said, for me, anything is all right. You shut it off, you put it, pass me. Okay, so what do you think? This is small baby. Should we have a air conditioner or no? No? Why? We'll get hypothermic. No, yes, you're right. That's smaller the baby. Okay, we don't want to. This baby may not be so small. But anyway, I just remembered that the candidate said it doesn't matter. If you are all fine, then I'm okay. So, come, who wants to?
Come on.
Come, 2 of you. Come on.
You want to point? We want us to point. Pointing is not nice.
Somebody who has not seen the case.
Even if you have seen the case, you are welcome.
You know, he came last time and he has yet to join pediatrics. He's waiting to join pediatrics.
They will all beat you up
So,
after you go out.
yeah. So he doesn't mind being wrong because he has yet to learn.
And we don't mind.
Even we have not learnt enough. So
Yeah.
come on.
We don't
2
mind
of
because we
you.
are always here. Come on.
If Anand Shandulya, our very close friend, was here, he would always say, those who want to pass first attempt, please volunteer. Even then nobody came. Come on. Somebody else for moral support. Okay, yeah. Come.
Holding the mic.
Go on that side. जी उधर जाओ, उधर बढ़ो, उधर पकड़ो, वो कैमरा से देखते हैं. आप इधर आ जाओ, आप इधर आ जाओ. Let us stand in the middle. She will be happy with the baby. Okay, ठीक है. Thank you. First, just observation, and Dr. Ulani tells us neurology is only observation. Okay, you hardly have to touch.
आप वो हाथ छोड़ सकती हो.
Growth, development, nutrition, parameters, sick, not sick.
The child is well looking. Nourishment is like moderate.
What must be his weight?
4 to
About
4.5.
Yeah. What was the weight? 4 kg?
Yes, right.
2.5.
They need to be quick because the child will cry and the mother will get upset.
The head is enlarged, dilated veins can be seen. There's a suture present over the left temporal region. And
Is the frontal depressed or bulging?
it's flat.
It is depressed. Okay, just keep that in mind.
हाथ रखो.
इसको ऐसे नहीं सीधा नहीं लेफ्ट साइड में सोता है ऐसे राइट साइड चल रहा है
There is a
The VP shunt can be seen on the left side, and there's a scar mark over the abdomen in the left hypochondrium. The occiput is flat.
Okay, the child is making all the. Is the child moving all the limbs?
The child is moving all 4 limbs.
Okay. When you look at the child, did the child look at you? आप अगर देखती हो तो आपकी नज़र को नज़र मिलाता है, और अगर आप ऐसा ऐसा करती हो तो ऐसा देखता है, एक ही जगह देखता है. बात करोगी तो हाँ हाँ ऐसे बोलता है, हो म्हणतो. You must also see upward gaze is there or no. He may follow side to side. If you go up, he may not be able to go up because upward gaze is the first to get affected with hydrocephalus. I think it's all right, sir. We don't want to do the details of. आपको कुछ पूछना है? Don't drop the head suddenly. Okay, हाँ. ले लो. दूध पी रहा है, उल्टी निकालता है. Anybody will drop her there. उसको छोड़ के.
So 3.5, but birth weight was 1.2, right? So then in the relevance of that, how much is the weight gain and what does it correspond to age? 1.2 has become 3.5. So 2.3 kilo weight gain.
Triple
How many
the
months?
birth weight. Triple the birth weight.
Triple the birth weight. I thought triple is 1 year. Correct? What is your comment on the weight gain? 1.2 has become 3.5. So 2.3 kilos. How many weeks or months it takes for a normal baby to gain 2.3 kilos? And then we will see whether his 3 standard deviation, etc., that is different.
On an average, what is the gain in weight per day? Pardon me?
30 grams.
Average 2.5 kilo in the first 3 months. Okay, simple. Now that you must be very quick. Okay. And therefore this baby has gained reasonably for a 3-month gain. Okay. We don't know whether it was an appropriate for gestational age or even not appropriate. That might mean further different. But even if it's an AGA, he could have started picking up a little later. He has gone through all illness. So from that point of view, he looks to have done well. And not all those parameters that wasting, stunting, no. If you look at his muscle mass, subcutaneous fat, it was not bad. So take a note of that. He is not stunted or wasted. He is fairly well. What does that mean? How is he well? He has gone through such a long period of ventilation. Okay, he was very preterm, and even then he has done well nutritionally. Why is that? Don't you agree? Very low birth weight, ventilation for few weeks, seizure, all that. Even then he has done well.
Exclusive breastfeeding, mother said.
So he has no difficulty in feeding, no problem swallowing and breastfeeding.
Adequate breastfeeding.
Very good. Good. So the impression wasting and stunting is not right. Okay, he looked pretty well on subcutaneous fat and muscle mass. Go ahead.
According to Dine's formula, the head circumference is more. So it's a macrocephaly. Head to toe examination. AF was open. The size was 2 by 2 centimeter. Bulging, non-pulsatile with sutural separation. No dysmorphic face is seen. No lesions at the back. Trunk is normal. Genitalia is normal. Left lower limb shorter than right one. Systemic examination. CNS BB is irritable. Tone increased in all 4 limbs. Power is 3 by 5 in all 4 limbs. Reflexes are 2+. No clonus. No focal neurological deficit is seen. Rooting reflex is present. Sucking reflex present. Morose is present. CVS S1 S2 normal. Heard. No murmur. Respiratory examination, air entry bilaterally equal, chest clear, and perabdominally soft, non-tender, no organomegaly seen. Summary. 4 months old male child, third by birth order, born out of non-consanguineous marriage, with significant birth history, with history of NICU stay with VP shunt in situ, partially immunized, belongs to upper lower class according to a modified Kupuswamy scale. Now presented with increase in head size and convulsion with high-grade fever spikes, is probably as a case of hydrocephalus. To rule out hydrocephalus secondary to intraventricular hemorrhage, post-meningitis hydrocephalus, congenital hydrocephalus, with VP shunt related complications, obstruction, displacement or ventriculitis.
I think we have mostly discussed most of these issues, and possibly all of them stands to be one of the causes. We have to go back and see what was exactly happening. Okay. If it was an intraventricular hemorrhage due to an extreme preterm, then it is grade 4, and therefore the child would have been very sick, as the child possibly was. and then he required a long-term ventilation, etc. So that looks all right. Meningitis, surely right at birth he was bad. So meningitis is less likely, and no congenital hydrocephalus. So very likely IVH, grade 4, and then all these things. But what are the milestones like? What is his developmental age? And is it proportionate to that grade 4 damage? That is what we need to look at. What do you think is the developmental age of this baby? You get the point? So tell us the motor, gross and fine motor, social adaptive language at 4 months that he has, and tell me whether his DQ is low, normal, and how low.
So there is a complete head lag. So
Yeah, but is there any explanation for head lag?
Just go back to your development slide. You actually nicely presented what it is, and let somebody interpret that. Somebody wants to interpret this and explain. He even gave you the answer, right? What is affected? How do you look at anybody who has developmental delay? Correct. How severe? Which domain? What is the pattern of involvement? And whether it's global or not global. Correct. Also, so till then we are in agreement, right? So what is this? Gross motor is affected much more than others, if at all. Others are almost, considering prematurity and other things are not bad at all.
Do you think hydrocephalus should start holding head in time? Then that is also not late, no? He has got a large head to carry. So he has a delay. So will you say he has no delay at all? What do you think? See, hydrocephalus child may get the next milestone ahead of holding head.
Skip milestones.
So do you think this is a normal for this, or you will still say that no, there is some motor delay? But the rest of the things are not bad. That puts me to say that grade 4 hemorrhage, etc. was unlikely. There is something amiss. Would you agree to that?
Yes, sir, absolutely.
And I think that is important. Looks like that head is lagging, so you could have found out in prone position how much he left, and then would have said he's almost like birth. Then it's not only hydrocephalus, he should have started doing something. But if he has a very large head, then he may not be able to hold at all. So that, I think, is a thing.
Yeah. So whenever you have something which can be accounted for that particular milestone loss, you may have variation in the developmental pattern. Normally, the development pattern will only occur in linear fashion. Nobody can learn to stand without learning to sit. And nobody can learn to sit without learning to turn. But there are situations where there may be a delay in sitting, but not so much delay in standing. Can you give me an example of that? You understand my question? Child was supposed to sit at 7 months, was not sitting till 10 months or 11 months, but instead of getting the same amount of delay in standing, started standing reasonably within normal limits. So when you have hemiparesis, congenital or acquired, before that time, because there is no support on one side, they don't learn to sit properly. But leg is always less affected than the arm. So standing is not as much affected as this. So you can have something similar to that in hydrocephalus also. As sir said, their head lag may be there, but sitting may not be as late as head lag, if otherwise they are normal. Okay? Same way, like Duchenne muscular dystrophy and all, you will see them as bottom shufflers. So they'll keep moving on their bottom but not stand easily. Anything else? No. So go to the final slide. Do you have any investigations with you? No. Okay.
How will you treat this child?
Most probably it's a shunt blockage or shunt displacement. So we'll put a shunt.
Sorry?
Shunt.
You would
VP.
put a shunt?
You want to revise the shunt?
Revise.
Is there any element of infection?
Sir, fever spike was
How
there.
will you diagnose infection in this child? Can the lumbar puncture CSF be not very abnormal and yet the child can have infection?
Will the CSF be abnormal?
It might be.
What
Might
is
be.
it called as?
Correct.
Sir.
Have you heard of ventriculitis?
Yes, sir.
They can have ventriculitis where the CSF drawn from lumbar puncture may not be as normal.
Why?
And therefore you have to draw a
But
ventricular.
ventricle fluid goes to the lumbar region. Ventricle CSF is formed here, that only goes to the spine. So there's ventriculitis due to shunt. So all the whatever ventricle fluid is formed goes into the shunt only and doesn't go down. Is that so? You get my question? No? It should, no? I mean, if there is a ventriculitis, your CSF should show. Newborn ventriculitis, your CSF is not improving, then you start thinking of ventriculitis. Right? In newborns, pyogenic meningitis, CF is not improving, you will think about ventriculitis, you will do a tap here and you will say, yeah, this is this. So if it's an obstructive hydrocephalus, then if it's a third ventricular obstruction, lateral ventricular obstruction, then ventriculitis may not translate over into your CSF. It's a communicating hydrocephalus, it will translate.
So
Sometimes because of that Freund syndrome where the protein is very high, you may not get the exact reflection of ventriculitis into the lumbar CSF. Okay, so these are some of the points.
So will you remove the shunt or you'll keep the shunt?
Revised.
Pardon me?
Revised shunt. So
Revise
you
sounds
have to
like
remove the
remove,
shunt.
wash and
Yeah,
put it
yeah.
back. So that's
But
not what
once you
happens.
remove the shunt, then
You're
the
right
child
in
will
saying it's
start
called
developing
revise. Sir is asking you a very clear question. Will you remove? Will you leave it? Will you remove and put it? If you remove and put it, will you put it on the same side or will you put it on the other side?
And when will you put
Simple
it?
question.
Remove it today and put it tomorrow?
So, fatafat, we'll answer that. We don't have much time. And we all can go back home at 8 o'clock.
So you must remove the shunt because you can't keep a foreign body and treat it. Ventricular fluid will be abnormal because it is ventriculitis. Once you remove the shunt, then there is no outgo for the ventricular fluid. It will start developing hydrocephalus. So you will have to do ventricular punctures from time to time. And intravenous antibiotic which you give may not reach adequate level into the ventricular. So often intraventricular therapy is required. So you don't go on puncturing the ventricle every day. So you put a Ommaya reservoir through which you keep on injecting the fluid and treat his meningitis, of which ventriculitis is a major part. And after the ventriculitis is treated and is free from that, then you reinsert the shunt on the other side.
Earlier we used to be taught high pressure shunts and low pressure shunts. Okay? And therefore all that we had was just put in a tube and hope that it doesn't drain excessively nor it drains less than required. So we are left to that. Today we get shunts which can be monitored in much better way so that there is no slit ventricle syndrome or an obstruction. All those are possibly now not going to be seen, though in a general hospital that may not be possible, and we put the shunt as a tube and hope that it will just do the right thing at the right time. But if it's a high pressure and low pressure, how can there be a low pressure hydrocephalus? Hydrocephalus itself means high pressure, no? What is low pressure? I can't understand. Because there is a high pressure, there is a hydrocephalus. So is there anything like a low pressure hydrocephalus? I thought every hydrocephalus is high pressure. Where is the problem? So what is low pressure hydrocephalus?
Pressure gradient to the chamber draining it and where it is draining.
Low pressure hydrocephalus is an intermittent high pressure hydrocephalus. So when you tested, you thought it was low pressure, but it's an intermittent. And why intermittent? Because the obstruction could also be intermittent, or an absorption could be intermittent. It's not a regular degree of production or taking away. And that is why it's high pressure only, but it could be intermittent high and not high, which was earlier called as low. And that's why just putting in some tube may not be the right answer. Usually it works, but it might cause a slit ventricle syndrome, or it may cause an obstruction.
Also, the urgency is usually decided on periventricular ooze. That means how severe is the pressure. It's equivalent of saying tension pneumothorax versus a pneumothorax. If I have to give a simile, that is how one would think. So if you see hypo-intense areas on sonography or on CT or on MRI, then you are in emergency or urgent need to next whatever hours that you can get a shunt in or do whatever decompression measures that you have to take.
I think one thing that may mimic clinically hydrocephalus in a small baby like this is multiple abscesses. Many of the babies who have had some problem are given some antibiotic, the meningitis is missed, so it becomes a partially treated meningitis, and that might lead to multiple abscesses, and those together look like a raised space-occupying lesion, and you have a bulging fontanelle, you have a suture separated, and you would call it a hydrocephalus. And when you do an ultrasound simply, you will see that there are multiple abscesses. And how do you pick it up? The child is already delayed, whereas a congenital hydrocephalus is not delayed. So why is he not delayed? You must have seen a very large hydrocephalus which is pressing over the cortex. Then how is the function maintained? You don't need cortex to maintain function.
How much liver you need to be not decompensated?
20% liver.
Does the thickness of cortex tell you something about milestone or not necessarily so? Not necessarily so. You can have very thin cortex because of hydrocephalus and the function is maintained. So it's not directly proportional to that. Also, I remember once upon a time we were asked how to test whether the shunt is functioning or no, whether the upper end is blocked or the lower end is blocked. I don't know whether it is valid.
It's not allowed. It's not recommended anymore.
Press the bulb here, and if it is the lower end which is blocked, then the shunt, you can't press the bulb only. And if the upper end is blocked, after we have pressed the bulb,
Sir,
bulb
don't
will
teach
not
them.
come up.
Sir, don't teach them. They'll say it somewhere sometime.
Yeah, it's given.
The idea is that's been given up because it used to lead to more fracture of the shunt if you regularly kept pressing, obstructing and checking. And it was not guaranteed, it was not a direct reflection. Best way to see is if there are signs of obstruction, there is obstruction.
And oozing is important.
Yeah, oozing, infection. When you have a case like this, you must be ready with answers on ventriculostomy, the Omada's reservoir, and endoscopic ventriculostomy, and the indications, and all those things. Main thing about which shunt to use, how to identify obstruction, infection, what to do next. If this shunt is not functioning, what will you do? What is a pseudo tumor in the abdomen for following a VP shunt? And these are the kind of areas where there will be discussion.
Fully grown brain, the cerebral cortex is 4 or 5 millimeters. And you need 1 millimeter also enough to function reasonably well. There could be some learning disabilities, etc. later, but that continue with us mostly even now. Or we are not called LD, etc., but we have. So that's not an issue. But two more things, that occasionally ascites could be a manifestation of a shunt. And that is because the lower end has a small irritation of the peritoneum, not necessarily infection. That irritation causes inflammation, that inflammation causes exudation. And I recall on 2-3 occasions, patient coming with ascites from the GI people, saying that we don't see the cause, and the cause is possibly the local peritoneal irritation by that. And one more complication which is talked of is shunt nephritis. How can shunt cause nephritis? How does it reach the kidney? Kidney is behind. So shunt nephritis is an antigen-antibody response to that foreign protein. And you may also get nephritis. These are rare. Obstruction, of course, you know. Infection, of course, you know. And you must know how to deal with obstruction and infection. He talked about whether you would do it on the same side, the other side. Would you do it at all, or would you now leave it? So is there any arrested hydrocephalus? So those are the issues to be discussed.
Hydrocephalus, just congenital hydrocephalus can be a long case. There are too many questions in that.
Thank you very much, everyone, and we meet again next Thursday, 6 o'clock. Thank you.
Thank you, both of you. Yeah.